Good morning to peripheраlinterventions.org and welcome to Mount Sinai Hospital in New York City. It's 8:15 Eastern Standard Time, and we have another interesting case this morning. Please post your questions to info@peripheраlinterventions.org, info@peripheраlinterventions.org. Let's go to room 6 with Dr. Krishna and his team.
Hi, Dr. Wiley. How are you? Welcome, everyone, to room 6. Really a pleasure today to present a great case. I'd like to welcome our team for this particular case. We have Dr. Christopher Varghese, who is our practicing interventional cardiologist and peripheral interventionalist here, who's actually kind enough to provide this case for us for your teaching purposes. We've got Anita Rajamanikam, one of our outstanding interventional fellows. Dr. Ray Lascano, we'll talk about the funding for his website soon. We have Elizabeth and Ricky as well. And I'd like to, just start with a little bit of a segue into this particular case. As you guys know, on the website, we have done pretty much every single possible case, trying to explore every aspect of endovascular intervention, showing the challenges, showing the different ways of being able to tackle them. From carotids to CTOs to below knee to venous to ASD PFO, you name it. And this is a very, very interesting case that brings up a certain set of challenges. And it's also, we're piggybacking it onto a very, very, I hate to say the pun, exciting moment because we have a randomized controlled trial really talking about how to manage this effectively. So I'm going to turn it over to Dr. Varghese to present the case, and we're going to get right into what we're going to do.
Lower extremity claudication despite exercise therapy and cilostazol therapy. He initially presented in 2011 with lifestyle limiting claudication in the right leg. Peripheral angiography revealed a chronically occluded SFA, from proximal SFA down to distal CTO. At that time, he was then referred for surgery, which he declined, and the surgeon felt as if bypassing the CTO would be of limited utility for him given its only claudication symptoms. He then underwent PTA of the right SFA in 2011, but then presented a year later with ISR of the stent and underwent repeat PTA of this ISR CTO of the right SFA. Recently presented to our office with lifestyle limiting claudication limited to about a half a block, at which point we brought him back to the lab and noticed that he had ISR CTO of the SFA stent again. We reattempted to get through the stent, but we were unsuccessful. And so he's here today for his repeat or reattempt at this CTO of the ISR of the right SFA stent. His past medical history includes hypertension, hyperlipidemia, has a history of CAD with known CABG, and BPH. His medications include aspirin, Plavix, cilostazol, atenolol, atorvastatin, lisinopril, and Flomax. He's a non-smoker and has no history of alcohol or drug abuse. Next slide, please. So his blood pressure today is 142/74. His pulse is 71. He's saturating 99% on room air. And on physical exam, significant, he has poor pedal pulses on the right side. So as we mentioned earlier, she came back about a couple weeks ago for a attempt at the right SFA ISR, but we were unable to cross the CTO despite several techniques. We used the Viance catheter. We used the glide wire technique with multiple 014 CTO crossing wires, but still unsuccessful. So we gave up about after an hour of attempting, and we talked to Dr. Christian and tried to bring him back here today to see what we can do.
Chris,
next slide.
The first time that you...
Okay, great. Well, I'll tell you, Dr. Wiley, if you look at this, I want to go right to the angiogram. So obviously, Dr. Varghese has tried to do this case, and it illustrates some of the difficulties that can occur in CTO. And honestly, I don't know whether we're going to get through. I mean, I have a good feeling that we will, and hopefully we will. But there's always a chance when you're talking about in-stent restenosis that you could get into a subintimal plane, et cetera, et cetera. But I wanted to just go over the angiogram. As you can see here, that this is the catheter, 7 French. We went with a 7 French sheath, destination sheath, placed at the level of the common femoral. You can see the patient has a robust profunda. Dr. Varghese has created a channel this time, so we do have a channel to get into. That may be a good thing or a bad thing, because it depends on where that channel is. If that's a subintimal behind the stent, that's a bad thing. If it's inside the stent, that's a good thing. So, when you're working in this type of situation, you have to take the good with the bad and try to adjust. Next slide, please. So you can see here that the distal reconstitution occurs in the above knee popliteal in the adductor canal, and you can see the slow is very slow, And you can see how there's a sort of swishing of the blood there. And to me, well, what worries me is that means that there may be a dissection plane communicating with the true lumen. That's what that looks like to me. But again, this is going to be the challenge of this case. Then if you see the runoff, you have 3 vessel runoff into the legs, and that you can see very well. I just want to highlight 2 points. First and foremost, the patient has been on exercise therapy and has been on salocitol, as Dr. Varghese just outlined. Second, the patient was referred to surgery, and rightfully so. I think the surgeons declined because he is a claudicant. Now, 2 things before we talk about what are the approaches, and I'm curious to see what everybody thinks. This is a very difficult, challenging subset of patients. First and foremost, there's until now, there's not been a randomized trial that's really taught us, what's the data regarding how to fix these lesions. But secondly, we've been using a lot of products off-label. I've been using it. I've done it live. I've always disclaimed that it's off-label. But for the first time, we have something that's now going to be on-label for the treatment of this particular disease. So the options of treating this, currently, I think the first option has to be what's called eczema laser atherectomy, followed by angioplasty, as per the EXCITE trial, which we'll go over a few minutes from now. Number 2, it could be just plain old balloon angioplasty. Plain old balloon angioplasty is what was tried compared to in the EXCITE trial, and clearly that there was superiority with the laser in this particular cohort. Number 3 could be restenting this. A lot of clinicians restented either with the DES, again off-label, or with another bare metal stent inside a stent. I mean, to me, the logic is, well, if a stent didn't work the first time, why would it work the second time? So I've never really restented, restenotic lesions. I've always done, other modalities of therapy other than stenting. Although the Cook-Zilver stent, at least on our anecdotal data, seems to have a little bit of, a utility in these type of difficult subsets, which is the drug-coated stent. Number 4 is a scoring balloon. Again, Spectranetics has the Angiosculpt scoring balloon, and obviously to score the lesion, create a large lumen, makes a lot of sense here. And again, that could be another modality that you could treat. Number 5 could be covered stenting. So there's been a lot of, again, it's off-label, a lot of thought and talk about getting through this lesion, scoring it, and then putting a covered stent on top of it to pretty much exclude the restenotic tissue, which is a possibility, and we can discuss that during the case. Number 6 would be atherectomy, which is again off-label. Actually, is something. It's actually in the IFU is contraindicated. However, we have done it, and I think it can be done safely. But the issue here is needs experience. And it's off-label, at least as far as I'm concerned. So atherectomy, there is data on it. Zeller's published data on it in JACC that looks at atherectomy for in-stent restenosis of the SFA. So clearly it has been done, has been published. So therefore, that's another option. Number 7 is drug-coated balloons. Or whatever number I'm on, is drug-coated balloons. So drug-coated balloons is another option here that we probably need to discuss. So I just want to say one thing before I turn it over to our wonderful endovascular fellow, Dr. Purushottam, is that what are the certain things that you need to do, and then we're going to start working on this. So if you look at the pictures, can you go to the pictures, guys? You can see here that I took 3 pictures of how to enter the stent. Okay, you can see it's a long segment stent, as Dr. Varghese pointed out. The key here is entering the stent inside the stent. So what we do is an angle tip catheter, such as the one that you see, could be any particular one, doesn't really matter. You want to make sure that you look in multiple views to enter the stent. So you see here, that's one view, always under high mag. You want to make sure that the catheter actually truly is not behind the stent. Because if you get started behind the stent, you're always going to be in a subintimal plane and you're going to have difficulties crossing. This is the second view, right? And I always do about 3 views to look at and convince myself that I've actually entered the stent. Number 2, how to traverse this lesion. I find when you have these kind of lesions with this kind of difficulty that Dr. Varghese have, I'm not going to go with a wire. I'm either going to go with a front runner catheter, which is a CTO catheter, or I'm just going to push this particular catheter through. So while we're working here, and we'll come back after Dr. Purushottam presents the data, we'll come back and show you where we are. Dr. Purushottam? Outside, guys? Okay.
Popliteal restenosis. So the incidence has been reported in the clinical trials anywhere from 19 to 37%, but I think roughly around 30 to 40% is a good number to remember, and this is usually for lesions of 150 millimeters or longer. And then when you look at the second instance or the second episode of in-stent restenosis after treating it the first time with PTA, it can be as high as 65%. And if you look at the slide, this was a Japanese group who kind of classified the in-stent restenosis into three classes, and as it says, less than 50 millimeters focal, and then if it's diffuse, it's greater than 50 millimeters, and a totally occluded ISR. And as you saw in our patient, we initially had a totally occluded and now what appears to be probably a channel. I won't go over these available therapies. Dr. Krishnan already went over, but all I want to say is that there hasn't been a very good randomized trial looking at any good treatment modality for ISR. And we got to remember that the stent volume is growing consistently every year from 5 to 7%, so you're going to see more of this. So I want to thank Dr. Eric Dippel for his slides, and so I'll be presenting the EXCITE ISR, which is the excimer laser randomized controlled study for treatment of femoropopliteal in-stent restenosis. So this was presented at the TCT this year, and actually this trial, once it was presented, it got the FDA really interested, and this is actually the only approved therapy for ISR by FDA. So this was the design. So essentially it was a prospective randomized multi-center trial. It was done pretty much across the United States. The idea was to see how safe and how effective the use of laser therapy along with balloon angioplasty was when compared to just standalone balloon angioplasty. So the principal investigators were Dr. Dippel and Dr. Walker. So they enrolled 250 patients from 2011 to 2014 this year, and essentially they wanted to compare the primary safety endpoint, which I'll go over at 30 days, and the primary efficacy point approximately at 6 months. So after they finally randomized 169 patients under the laser arm and 81 patients under the standalone balloon angioplasty arm. So these were the sites, and Mount Sinai Medical Center was one of the study sites. So currently Spectranetics has two catheters, the Turbo Elite and the Turbo-Tandem, and I think we plan to use the Turbo-Tandem in our case. So the inclusion criteria, so any ISR lesion greater than 4 centimeters, patient had to have a significant lifestyle limiting claudication, and they used a reference vessel diameter from 5 to 7 millimeters and had to have at least one or greater patent infrapopliteal vessel. The exclusion criteria was if the target lesion extended 3 centimeters beyond the stent margin, if there was an untreated inflow lesion, and grade 4 or 5 stent fracture. Now the stent fracture is essentially classified as if there's one stent fracture, it's 1, if it's 2, then it's multiple, 3 if it's more than multiple but not dislocated, 4 and 5 is when it's dislocated and you have struts sticking out. And the box on the top, that's what you really see in real world data. You really don't have a lesion length limit. You can see multiple variations, different stents are used. So that's what was very good about this trial. They try to keep it as real world and experience as possible. And they followed up these patients at 30 days, 6 months, and at 1 year. So the primary endpoints, the safety endpoint was looking at major adverse events all the way through 30 days, which included death or an unplanned major amputation or target lesion revascularization. And then the primary efficacy endpoint was essentially freedom from clinically driven TLR at 6 months. So it was a duplex ultrasonography binary restenosis, which they used a velocity of 2.5, and then return of clinical symptoms and deterioration of ABI of greater than 0.15 or Rutherford classification, which deteriorate category down.
Category 1?
So, category 1, sorry. The sample size, as you know, they wanted to achieve a power of 80%, and so these were the numbers. So the study was adequately powered, and in fact the FDA was so impressed with the results that they actually recommended that the enrollment can stop pretty much 3/4 into the trial. So these are the baseline demographics. As you can see, all the standard risk factors and things which you think can affect your ISR were included, and they were pretty well matched. And these were the lesion characteristics. As you can see, the mean lesion length was approximately 20 centimeters, so pretty long lesions. And if you notice that the patients who were randomized to the laser had a little more calcification than the others, but otherwise most of the lesion characteristics were pretty well matched. And it's important to know that 20% of the lesions were greater than 30 centimeters, so very close to what we see in real life practice. So procedural success. So procedural success was essentially defined as finishing up the procedure with a residual stenosis of less than 30% and without having any complications or such as bailout stenting or doing anything more. So here, if you look at the comparison, the laser arm had greater procedural success, which was statistically significant, and also the residual stenosis was far lesser in the laser arm, which was also significant. And as you remember that there are two catheters, the Elite and the Turbo-Tandem, so 80% of the catheters used were the Turbo Elite. So this is the procedural complications, and if you look at the left half of all the bar graphs, and you can see that the laser arm did very well with regards to procedural TRR, any dissection, and then grade C, and finally bailout stenting. And the others, even though as far as embolization, thrombosis, and abrupt closure, they were not statistically significant. And these were adjudicated by an independent clinical evaluation committee. Sorry, I just wanted to make sure. So this is the primary safety endpoint at 30 days. And what you can see here is it has 3 sets of TARs. The left 2 ones are the ones with the intention to treat. So intention to treat were those patients who were randomized to the laser arm or to the balloon PTA arm, and their analyses were presented based on what they were randomized initially. It doesn't matter if they crossed over or jumped over to any of the groups. And they also did the per protocol analysis right at the right hand side corner. And usually the FDA likes to look at both the intention to treat, which the statisticians think is the most accurate way, and per protocol if you want to be a purist and see what really the device did. And clearly you can see that the laser arm did well when compared to standalone balloon angioplasty, which was quite statistically significant. And now when you look at the primary efficacy endpoint, which is essentially freedom from TLR all the way to 6 months, so you notice that again the laser arm did better than the angioplasty arm, and some of the relative risk reduction was pretty much as high as 30-40%. So these are very impressive results in this randomized trial. And these are some Kaplan-Meier survival curves, which reveal the freedom from target lesion revascularization. And the blue line represents the laser arm, and the yellow one, which is the standalone balloon angioplasty. And clearly you can see that patients who had the laser therapy had a greater freedom from TLR. And then looking at the same data without the bailout stenting, the reason they did this slide was they wanted to give the benefit of doubt to the balloon angioplasty. For example, you do a balloon angioplasty, you see a nasty dissection, you put up a stent, and that can technically be considered as the first TLR, but even if you excluded them, you can still see that the laser arm did pretty well. And this was again statistically significant on this representation of the Kaplan-Meier survival curve. And again with the primary patency, similar results with the laser showing it did better. And freedom from major adverse events, taking it all the way to a year, you see that the laser arm once again did far better than the standalone balloon angioplasty. And then these are some Cox proportional hazard analysis. So essentially trying to see in the different subgroups if the laser really did well. Essentially all across the groups it did really good, except for the diabetes arm, where it does cross over the unity line. And then finally, when you look at by lesion length, clearly as your lesion length progresses, you can see that the laser arm does really well, where you can see most of the graph with the confidence intervals are way away from the unity line. So in conclusions, what they said was essentially that laser therapy was considered superior to standalone balloon angioplasty for the treatment of ISR. And it's important to remember that these were complicated lesions, averaging 19 centimeters. There was a higher procedural success rate. There was a higher safety rate and also a higher efficacy rate with lower TLR for the laser arm. And also important to note that this is the first FDA-approved device exemption randomized control study which revealed the benefits of especially laser atherectomy in the lower extremities.
Dr. Purushottam, so this was a superiority design trial and not a non-inferiority trial?
That's right.
Okay. We're joined this morning by Dr. Danny Sofer, who's here with us. It's a pleasure to have him this morning with us.
Hi, Daniel. How are you?
Hi.
Thank you so much for joining us. It's a real honor to have Dr. Sofer with us. You know, he's part of our team here at Mount Sinai, and his experience is incredible. So Dan, we've had a very difficult case. I just want to present it to you. You know, it's a patient with an ISR that was failed, and it looked like, Dan, what happened was at the distal end of the stent. I'm going to go back to you with the view where we were having trouble, and also for the viewership. At this particular area, it seemed like we were going outside the strut into a collateral, which I'll show you later, Daniel. So what we decided to do at this stage was we initially went with that. This is very important for the audience because we went with that aqua tempo catheter, which is it could be any vert-tip angle catheter that you use to move away from that dissection plane that was created. Then the key here was we went with a front runner because it's obviously a very fibrotic cap that was deflecting Dr. Varghese runner into that collateral. So it's important to have that angle catheter to point away from that plane and go with a front runner type device or a hard device. This obviously you can see here, and I want to demonstrate to the audience that you can see how this particular one shows that the struts are moving. So we were still subintimal at this stage. So I was a little worried about advancing it into that, and I'm just showing you different things that we tried. Then what happened was we went ahead and we found another plane, and I think that's incredibly important to find a plane. Once we found another plane, we decided to switch out to a Confianza type wire. And then you can see here, we threaded the Confianza wire, and it looks like it's the strut. Very important for the audience. I know Dr. Sofer and Dr. Wiley, being experienced, they know this, is very, very important that you need to see whether you're truly inside the lumen or outside the lumen. So what we did now is we went ahead and took a couple more pictures. This is another RA or LAO view, and here's another view showing it looks pretty on top of the stent, but not quite outside. This was kind of concerning. So I did another view, and it clearly shows that you're now inside the stent strut. Then what I did was I walked out my aqua tempo because it would not advance, and I advanced an 018 trailblazer, or quick cross through the lesion. So here's an 018 quick cross through the lesion. I've got blood back. Then what I did was I advanced an 018 wire, which is our V18 wire through the lesion, and now we've got it done. So currently we've obviously now traversed this lesion. I believe we're in the true lumen, and while we set up our laser to do the EXCITE trial, I'm going to let you and Dr. Sofer talk about what are the things that you guys would do in these type of cases.
Well, I have a quick question. Why was surgery not a good option? The indications to treat femoral popliteal lesions are still lifestyle-limiting claudication, not critical limb ischemia.
Well, I think that's actually a great question, and I think in the past when we didn't have trials like the EXCITE trial to really get us excited about treating these type of lesion subsets. Can I get a filter, guys? Can I get an 035 trail quick cross as well? What's important is that now we have a randomized trial showing that this is more effective than the standard therapy that we've had. So you saw that the beautiful presentation that Dr. Dipple had done and his team had done in the TCT. You see very, very clearly that you have very, very acceptable rates in terms of TLR rates and so on and so forth as was presented. So I think it's probably fair at this stage to go ahead and try this modality of therapy here, and then if he fails this, then maybe a discussion could be had about surgery. That's my opinion. I don't know about what do you think, Dr. Sofer?
First of all, that was a very good work that you did going into the distal distal edge. I haven't seen the original. I assume that it was a diffuse in-stent restenosis or occlusion.
It was an occlusion, Dr. Soper, the first time.
Across the entire length of the stent?
Pretty much.
And how is the runoff?
The runoff is 3 vessel, Dr. Soper.
3 vessel. So,
look on the wire.
You know, this is very exciting time. This is the first trial to show that atherectomy is actually reducing all TLR and major adverse event through a year. And I think the decision to choose a filter is a good one, because there still could be, with the laser, even though it's a very safe device, a atherectomy device, there could be some distal embolization, even though we have 3 vessel. And I think it's a good decision to use the filter. And do we have the drug-eluting balloon?
We do, Dr. Sofer, we do, and that's one of the options that we have for this particular case. We have the drug-coated balloon. We also have the drug-coated stent as well in this. But I mean, so I think that's why this case is such a great case, because it brings up all the discussion points that you're just talking about.
Right.
So would you do? Okay, give me then give me a 3.0 balloon from any one of the 3.0 balloons. Can I have the Trailblazer? I mean the 018 Trailblazer now.
You know, in the initial trial, the patent trial, they use the Turbo Elite first, and then they use the Turbo-Tandem. You know, using 2 atherectomy devices that can increase the cost of the procedure. What laser catheter are you going to use?
Well, I have actually decided here just to go with the Turbo-Tandem, and what is it? Oh, it's stuck. There you go.
Are you guys pre-dilating?
Well, as you can see here, guys, this is such a fibrotic lesion that we're having a hell of a time passing anything through. So I am not going to go ahead and try to pass my Turbo Elite through this. The current recommendation of the use of the Turbo Elite recommends that you have at least a 2 millimeter channel for the laser to go through. So what we're trying to do here is to create a channel. So what I've done is I'm going to switch out, because it's such a fibrotic cap that was, no, I need a wire. I need a Grand Slam. It's such a fibrotic cap that's not allowing us to pass even an 018 balloon. So therefore, at this stage, what we're going to do is we're going to balloon this with a 2.0 generic balloon, whatever it may be, and then be able to switch out for a filter. And then again, like Dr. Sofer so nicely said, it's really probably overkill. But I've always become a point that there is so much thrombus associated with ISR cases in my experience that I tend to err on the side of using a filter. Obviously, the only on-label filter at this stage, and that's only on-label for calcific lesions, is the Spider FX. So we will go with the Spider in this particular case. So then after that, we will go ahead and do a Turbo-Tandem across this. Probably a 4-quadrant cut, demonstrate how to use the prep the catheter, and then how to use the catheter, and then we'll go ahead and do probably an angiosculpt, and then leave it for discussion based on how it looks.
Would you consider using a 0.9 Turbo Elite atherectomy first, opening a channel, and then perhaps going into the Turbo-Tandem? I
think that's how, like Dr. Sofer so nicely said, that's how it was studied. I think that's a possibility, but because of the other options that we have available, the additional use of the angiosculpt is going to add some cost to us. Maybe Spectranetics can bundle that together, which is what I'm hoping in the near future that they'll do that. But the point is, so because of those additional costs, I think I'm going to do what's necessary, and I also don't know whether I am going to go ahead and do a drug-coated therapy here after that. So you can see we're having a tremendous trouble here advancing this wire, but we finally got this balloon. But I'm going to try to get it down a little bit further here, just to make sure that I'm in the true lumen. Little rail, guys, real rail. Pull on the wire. Keep pulling on the wire. Don't worry about it. Good. So that's a very important technique that Dr. Bosker was demonstrating, right? So what you want to do is pull on the wire and push on the catheter. It's sort of like a push-pull. It's counterintuitive in order to be able to get it down. Come forward. Okay. So we're going to go up with the balloon, and I'm very, very curious to see the expansion of this balloon. Go up, guys. So I'm just going to go up just to see in the spot that I'm concerned where I'm having trouble, and we'll see. This will tell us a lot. If it squishes the stent to one side, we're, you know, for lack of a better word, we are, I don't want to say that word, do I? No, I can't say that on national TV, right? No. There you go. So you see that in 6, with a 2.0 balloon, I was able to crack that lesion, and now you can see that I'm clearly within the stent. You see that? I'm within the stent in all angles.
That's how much? 2 millimeter diameter?
That's a 2 millimeter regular non-compliant balloon just to go ahead and open it up. Now, Dr. Bosker's go to 14 now for me. So really to expand this lesion out, so this way I can get the Turbo-Tandem down. And then I'm going to try to place this wire in the right area. There it goes. It seems to be a little better there. If I can get a C-loop here, I get very excited. But unfortunately, yeah, now it's cooperating. So we're now down into the distal. So now I'm happy with this down. And I think for everybody at home, you know, this is what demonstrates what you want to do here. It's the thought process. You know that your colleagues, Dr. Varghese, incredible operator. So you want to know that, okay, well, there's a reason why this happened. Walk this out carefully, Bhaskar. So therefore, you want to make sure to take steps. And it's important if you guys at home get films from other operators who have not succeeded. The reason is that there's something difficult in this particular case. And here it was very clear, because when we went down, when Dr. Bosker was presenting his the trial, we actually went right into that side branch, which clearly showed what the problem Dr. Varghese and his team were having. So right now, what we're going to do now is we're going to get our filter ready, and I'm going to show you how to deploy this filter to save time. So and then we're going to prep the laser, and we're going to GO, as Dr. Sharma would say. So here we're going to go with our 035 quick cross, which is going to go into the distal vessel, and then through the quick cross we're going to deploy the filter, which is going to save a step for us. Okay, rail please. And I'm going to let Dr. Purushottam, because he's extremely well adapted in actually using the Turbo-Tandem. He's very, very quite good at it. I want to let him demonstrate his techniques. So let me have the thank you. So look at my hands, guys. So what we do to save a step here is we got the 035 quick cross here. We're going to take our filter. We're going to push it in as far as it goes, okay? And then once it stops going forward, which is right there, I'm going to ask Dr. Bosker to push the wire. And then once that wire frees up, Dr. Bosker is going to walk back the delivery system. So what this does is essentially saves us a step, right? And when we're dealing with all these long peripheral cases where we have so many steps that we have to do, it definitely helps us not to save a little bit of time. Even a few minutes saved here and there adds up, as all you guys know. So we're now going to get this down well deep into the popliteal. A little bit of difficulty pushing it, which is fine. And there we are. So now I'm in the popliteal. Now I'm just going to walk this out. So now my filter is well situated. I sized the filter to what I thought was the popliteal, so it's a 7 millimeter filter. And now our nurse practitioner Ray is going to show you guys the steps of prepping the Turbo-Tandem. Can you guys?
What mode of anticoagulation are you using?
That's an excellent question. As you know, we're predominantly a bivalve-Rudin lab. The safety data with bivalve-Rudin has been established in peripheral vascular disease, and we've been using bivalve-Rudin here. Obviously, you can use it on heparin as well. So now, so if you guys can come here to show the catheter, Ray, can you show them the catheter? So the Turbo-Tandem is a wonderful feat of engineering, because what they did was they actually took the laser and they placed it on for lack of a better word, a pedestal, which would then allow the laser to be abutting up against either wall and give us the ability to really do a 4-quadrant cut. So Ray's holding the handle here, and the handle will help push the laser forward onto the pedestal. So when we engage the laser into the lesion, you want to be on that pedestal, and you want to do a nice slow cut. Okay, don't want to be too slow, don't want to be too fast. Obviously, embolism occurs with every atherectomy when you're going fast. And then once you do that quadrant, you can pull back, torque the catheter to another quadrant, and go all the way down. Generally, we like to do 2-quadrant cuts, after which we will take a picture and then decide what else we need to do. But in this particular case, we may end up doing 4. But so that's what's important. Second, the laser machine, this is the newer machine that they came out with, which we're very happy with, which is, it's not quite an aircraft carrier, it's a battleship. But it's believe me, that's an incredible feat of technology to shrink what they had. But clearly, this particular one is much easier to use in our lab. It's able to fit in tight corners, as you can see. And again, it also has to be warmed up like always and calibrated, so which we did offline. So now Ray's going to go ahead and calibrate this. You have to bring the laser to the pedestal to go ahead and calibrate it. So now he's going to calibrate it. Obviously, look away, wear your protective goggles, do all those things that you need to do. Once it's calibrated, now that it was very simple, we're going to go ahead and enter the laser into the body.
Now, what settings are you going to be using?
What are the settings we're going to do, guys?
45 and 50.
Yeah, well, in our lab, we start at 50-50, Jose. And that is pretty much the recommendation by this company. Second, when you put the wire in, there's 2 different areas you got to be careful. The wire, it's not a monorail system. So you have to make sure that you get it into the right lumen for the wire to come distal. Obviously, with my old, 50-year-old eyes, it's pretty hard to get this in. That's why I have young people like Bhaskar to help me. But I'm going to try a few minutes. Dr. Wiley, I heard you have very good eyesight. Is that true?
I'm working on it. It's getting better. Why are you using this device versus the Turbo Elias? Because of luminal gain or what?
Well, first and foremost, this was the device that was studied. I'm not able to get it. This was the device that was studied, right? Second, we're obviously going to be able to get more luminal gain with this particular device than we are with the other device. And one of the criticisms of laser has always been that we could not, get enough of a lumen with the laser or have directability of the laser. So therefore, this particular device solves all those problems for me in my lab. Third, the fact that I can actually steer it is also a tremendous help to me to be able to go through different quadrants. And we're actually going to go ahead and do a volcano IVUS here to go ahead and show you the lumen that we get. So again, it's not only my eyes, it's also Dr. Bhaskar who's having trouble, so I don't feel as bad. And again, we might have to turn it over to our Anita to go ahead and put it in.
So and this is a quick question more for Dr. Purushottam, since he was talking about the trial. Interestingly enough, there were patients that had calcified lesions in this trial. Do you mind elaborating a little more on that, Dr. Purushottam?
Could you say that again? Dr. Wiley, we could barely hear you.
In this trial, there were a significant number of patients that had mild to moderate calcified lesions.
Yes.
And as you know, normally a laser has not been indicated or advocated to be using calcified lesions, but in this trial, a significant number of the patients did have calcified lesions. I don't remember the number. Probably Dr. Purushottam.
It's definitely a number that's not a small number. But remember, it's a question of whether it's adventitial or medial calcium, right? So remember, and I think the issue here is with angiogram, you're not really going to be able to tell. And I think it's kind of a misnomer in our experience with lasers to say that it doesn't work in calcium. It's probably a little less effective in calcium. But the beauty of this trial, in my opinion, was that it's a real-world trial. It was all comers, all lengths of the SFA, right? So this trial actually did what we're doing in clinical practice. This is a patient that Dr. Varghese appropriately sent to surgery, was asked to do a percutaneous intervention on, went ahead and brought him in, and we're doing it. So therefore, it really encompasses patients that we treat in every day. This would have been a perfect EXCITE trial case, if I'm not wrong, guys, right? This would have been a perfect EXCITE trial case. So therefore, I think that, yes, you're right. I think it is surprising that the numbers were that high, but clearly, I think it's also enlightening that this particular device works in those trials. Dr. Bhaskar, do you want to take over and show them how you're going to do this?
You guys want to show the camera up here?
Huh? Oh, I got to wear my glasses. Sorry.
Can you focus on this green little thing?
Aren't these glasses enough?
So what you see is these 2 discs, and you also got to look at the fluoro.
Okay.
And what you see on the fluoro is you see the distal marker is like a rectangular radiopaque shadow, and the proximal one is the square one. So the square one is where the laser is mounted on. So what you do is
now show his hands, guys.
So you bring these 2 discs together and you look on fluoro, and you want the square one to sit on top of the
That's okay.
the rectangular one. So it almost looks like a little car there. And then, because now it's off the ramp.
Now, very important, you know, to have a great nursing team and tech team like I have. Elizabeth told me to make sure I turn on my flush. So obviously you don't want to have any contrast to prevent any explosions, although we've used explosions. Number two, once the flush is going, we're letting it wash out, and we're going to do it on the floor to show that all the dye is washing out, right, so we don't have any explosions. And so now we're going to go ahead and start. Now Dr. Bhaskar is going to go ahead and allow me to do this, and I'm just going to engage the laser. Okay, ready guys? We're going to start on this medial side right about here. What do you guys think? You like that? I like that. Ready, go? Okay. There you go. So you got to be ambidextrous with your legs. Ready? Are we ready?
They got to hit the ready button. Yeah.
Okay. So remember, Dr. Bhaskar is just giving me a rail, and I'm just moving very slowly in this particular quadrant. You know, we always tease the laser guys that, you know, we need to get earmuffs, but the point is it really works very well. So if you can't hear me, I'm going to just raise my voice and yell. So you can see I'm allowing the laser to work through the stent. And as you can see here, it's starting to rotate. And the beauty of this is I can always rotate it back. You saw that? So I'm always going to try to hold it on that plane the way we used to do with the Silverhawk.
So you're avoiding it to gutter one way or another.
You can. So
And
Elizabeth
you can stay
is
away from the struts.
Well, you know, I don't know, Dan. I think it's impossible to stay away completely. I think that's because, you know, we're doing obviously an atherectomy of this particular vessel, but I'm trying my best to really move it forward without jerking it, and really trying, you know, obviously it's a very tough lesion. That's why we, you know, Dr. Varghese had a difficult time crossing it, and you know, this is part of what we do. So I'm going to stop here, give the patient a little bit of break. I want everybody at home to go check their filter, right? Check their filter, and the filter is still in a good position. So now we can come back again, and we're going to start again. Ready?
Yeah, ready?
So you can see here, you know, I'm going a little fast, I would say, and I'm going to slow myself down here a little bit and really let the laser work. You know.
What are they recommending? A centimeter per second or what?
Not a centimeter, I believe it's a millimeter.
Millimeter per second.
Let's put it slow.
Yeah.
So I'm just slowly advancing it. I mean, Dr. Sofer, what's your algorithm for ISR in today's you know, market of so many items that are available?
Yeah, I mean, this is obviously, those patients keep coming. You know, the patient that had the long occlusion or in-stent occlusion or restenosis, we really didn't have any good solution. I mean, I have patients that I tried all the atherectomy devices and they still kept coming until I put a drug-eluting stent. You have to watch them very closely because the goal is just to make sure that the stent is still patent. But this is really a breakthrough, I would say, in in-stent restenosis, diffuse in-stent restenosis. And I think with the combination with the drug-coated balloons,
No, I got it.
it's going to give us a good answer, hopefully long term.
What about you, Dr. Wiley?
I think it's a great device. As you know, the other atherectomy devices were not indicated for this. There's always a risk that for instance, with Silverhawk, that it could get caught in the stent struts.
Right.
I think this is a safer device. The fact that most of this in-stent restenotic lesions harbor thrombus is a positive for laser, since it vaporizes the tissue right in front of it. So
I think that's a great
idea.
point. Yep, absolutely. Right. So there we made our first pass. Okay. Now I made my first pass. Now I'm going to actually now when I walk it back, I'm going to go ahead and pull it back onto the pedestal, and we're going to walk it back. Go ahead, Bhaskar, show them how it's done. Show his hands, please, so you can watch both the screen and the hands. So you can see here, it's a very simple device to use. Dr. Bhaskar is going to press the two buttons. Go ahead, Bhaskar, describe it. Watch the wire. Go ahead.
So what you got is you got these two clips here. You bring them close to each other, and then
disengage.
You disengage. You see the square thing come all the way back.
So now that's very important. Now this is a regular laser. It's standing in the position. And you also saw in demonstration the luminal gain that we're getting. Show me down below, guys, so I can see my filter. The luminal gain that we're getting. And you can see our filter is still in a good spot here. That I'm going to go ahead and leave it there. I'm just going to go ahead and walk this out. You know, it's a little tight, obviously, because of the laser in itself. Thank you. And see, this is a great thing that Dr. Bhaskar is doing. It's giving me a little bit of fluids, which is helping me push the wire, right? And, you know, a lot of times, guys, I'm telling you, with these long over-the-wire devices, whatever it may be, and it's not the fault of any particular device, it's important to sometimes take it out, flush the center lumen, wipe it down, and go back in. These cases may take a little longer. Everybody may get a little, you know, oh my God, it's not as quick as a balloon stent. But guess what? You've got randomized control data that shows that it works. You've got a device that's effective in debulking, but you just don't want to get into technical issues such as the wire sticking, et cetera, et cetera. So you see, now we're out. So I'm going to have my team flush the center lumen for me while I take a picture, right? So let me just, yeah, there you go. It's very sticky on the wire. So we're gonna flush the center lumen, and then what we're going to do is we're going to take a picture.
Prakash, if the data of this trial was so compelling with laser and a plain old balloon angioplasty, why would someone consider drug-eluting balloon or drug-eluting stent if we believe this results?
Yep. I'm sorry, Jose, I missed that.
Yeah, if the data of this trial was so compelling for in-stent restenosis using laser plus plain old balloon angioplasty, why would someone consider a drug-eluting balloon or drug-eluting stent when the cost will significantly increase?
Why wouldn't somebody consider drug-coated balloon, you're saying, in this particular case?
Yeah, I mean, the data of this trial was quite compelling,
right,
using laser and plain old balloon.
Right.
Why would we use a drug-eluting balloon or drug-eluting stent that hasn't been studied in this particular setting?
Well, I think I think part of the way the field of cardiology advances is by doing things that on our patients that we feel are safe and effective. But at this stage, I don't see any reason why to. I think that this exact trial has proven in a randomized control manner, right, that the laser with the balloon is superior to the balloon alone. And that's our plan here, is to try to do it. When I would try to do a drug-coated balloon is probably if this patient came back again. And I'm assuming that the pattern of restenosis that Dr. Sofer talked about is going to be a little bit different when the patient comes back. This is a long diffuse restenosis. If I can get it back to a focal restenosis, then what I'm going to go ahead and do is then maybe to do a drug-coated balloon or a drug-coated stent of that focal restenosis. You know, this is a challenging lesion subset, and that's a great question. But at this stage, I'm only going to leave this with a laser and balloon and provisional stenting if for whatever reason I don't like the way it looks.
Also, to answer, I think that the results with the drug-coated balloon alone are promising by themselves. So I think the combination of photoablation and then delivering the drug deeper to the intima will probably have even superior results. I would assume there is a trial, a randomized trial, multi-center randomized trial going on in Europe, I think now.
Yes, yes, absolutely. I think it's Jos Vandenberg who's doing that trial up in Europe, and I know Jos was at our conference last year, and he spoke about that particular data. Dan, you're absolutely right.
Yeah, I agree. Unfortunately, the data's not available yet, so we got to go with what we have available.
Well, I don't think it's wrong. I think Dan, obviously, with his experience, will agree that, I mean, as cardiologists, we've always been sort of on the cutting edge, kind of ahead of what really became approved and doing things earlier on because we knew that was superior or not superior. So I can tell you that, this is not a wrong thing to do. So as you can see, the only thing that we need to get is some Pearl Vision prescriptions for me and my team. Well, Dr. Wiley, I wish you were here to put this in. I really do. You're so good.
Yeah, you guys are in the 50s. That's what happens.
And I always tease our spectranetics folks that we can't see and they always tell us they'll get us new glasses. So, you know, we're struggling here getting this in, but obviously, believe me, guys, at home, it's not that hard. It's just that, you know, we're on camera, and I guess Dr. Bosker's a little nervous. Why don't we turn it over to Anita this time? Let's go, Anita. Let's try you. And, you know,
saline in it, so with the refraction, it makes it a little more challenging.
What?
look at that. He's actually using physics terms. He's actually using physics terms.
I know.
All right, just don't poke me in the eye with. Oh, I got my protective goggles on. All right, ready? There you go. So again, now remember, we're going to keep it wet. So I want that wet. You know, I want you to keep your hands wet, and you know, I want Dr. Varghese to flush after just for a little bit. So you know, these are the little tiny things I think in our experience we've learned that really has really turned out, you know, to help us. So here now I'm flushing again, and again I'm just going to check to make sure that all the dye goes out. You know, yep. Thank you. Pull.
Prakash, is your plan to do 2 passes or 4 passes?
You know, that's an excellent plan. That's an excellent question, Dr. Wali, and I'm really curious to see what Dr. Sofer says too. You saw after that first pass the effectiveness of the actual Turbo-Tandem in getting a luminal gain. You saw that the lumen was much bigger. So what I'm going to do now is actually do what we call as a lateral pass, and then we're going to talk about doing. I think what I will do at that stage is just to go ahead and just do a single 2-pass cut, and that's it. Now I'm going to go in. Now we're completely flushed. We're obviously not going to move that filter if we can, right? There you go. You take over. Thank you. And now we're going to go down. And again, you know, I want everyone to be careful, you know, because these little things go ahead, and Dr. Bhaskar is going to load the laser. The little things of moving the filter, not moving the filter, and cause dissections distally can make a very elegant case not look very good, you know. So, you know, we want to be very, very careful. See how nicely he's loaded it on? Now what I'm going to do is actually rotate the laser. You see this? So I'm just going to physically rotate the laser. There I am. Now I rotate it. Now I'm going to pinch it. I'm going to ask Ray for a dry gauze here. Ray, a dry gauze, buddy. So what I'm going to do is, as they pin the wire, I'm going to rotate the laser even more. See there, I got it rotated, right? So now I'm going to go ahead and rotate, and I'm going to engage. Oops, start. Yep. Thank you, buddy.
Dan, would you use laser now as your first-line therapeutic device for in-stent restenosis?
Based on the data in long in-stent restenosis and occlusion, that would be my first choice. I mean, ideally, regarding to the question about 2 passes of 4, ideally you probably would like to do 4 in all different directions, and it's pretty safe. You're inside a stent. But this is a question of time and fluoroscopy and all that. But ideally, I think 4 passes would be ideal. But I think with 2 you can get enough luminal gain.
Followed by balloon angioplasty.
Followed by at low pressure.
So that's a very interesting concept, Dan. I agree with you there, absolutely. I think that what you said is very much on the ball right now in terms of what we should do in our practice. Oh, I'm fine. Okay, yeah, go see the filter. See, this is very good. When Dr. Bhaskar asks us to see the filter, it shows that he's unsure, and we need to see the filter. And you see the filters come back a little bit, but it's still reasonable. But remember, that's very important to allow your team to talk to you and let you know what's going on. You can actually let the filter go a little bit. So you don't want that filter to come back into the stent, guys. That can create a lot of trouble. So, you know, it's very important to communicate with your assistant, you know, a fellow, whoever it may be, and do this. So you can see a little bit of trouble here pushing it, but it's going. You know, again, it's really a feel thing. So, you know, I've got my laser pinched in my hands, which is not, again, you know, not really affecting my my ability to move the laser in any way. So I'm just going to go ahead and get through this little zone, and now it's just moving because of the momentum that I built up.
So when would you decide to use a scoring balloon after this laser
You know,
versus
honestly,
a regular balloon?
I'm looking for luminal gain here, and stop. I think the angioscope scoring balloon. Show me this one. The angioscope scoring balloon is going to give me the luminal gain that I'm looking for. There you go. Good. Come back. So that's the reason I decided. And you know, I'm going to speak to the good folks at Spectranetics and really ask them on behalf of all interventionalists to bundle it together. Let's see what they do. You know, they're really good guys and gals, so maybe they'll do that.
What size stents are those? 7.0?
Dr. Varghese, do you know what size they are? Dr. Wiley, any questions or anything yet?
I haven't checked out.
What's the longest scoring balloon that we have?
I believe the longest is 200. Now, you know, the nice thing about their scoring balloon is that it's been re-engineered where you know the elements of the scoring don't bunch up. They used to bunch up in the longer balloons. I really haven't been seeing that since it's been re-engineered. Obviously, there are different types of scoring balloon, and for educational purposes, there's one that's made by Trireme that's called the chocolate balloon, which is a different type of scoring. But I think you know, I really believe that the angiosculpt has proven itself not only in the coronaries, but also obviously in the peripheral vasculature as well.
Tight down there.
So you can see I'm having trouble pushing it here. So what I may do is go to another plane, because this is the area that Dr. Varghese had a lot of trouble getting it down. So I'm just going to go to maybe an anterior posterior plane here just to get through this area, maybe right there. See? And then maybe as I go through, they recommend you don't torque as you go through, but I'm just going to go ahead and do that.
So would you use this device on de novo lesions?
Absolutely.
And when would you decide to use this device versus other atherectomy devices?
Off. For me, Dr. Wiley, I'm telling you, this device works really well in any sort of area where you need to debulk the lesion prior to putting any sort of secondary therapy. So, you know, as you can see, again, we're having issues with the tightness around the catheter. Oops, that's because I forgot to bring it back. Look at that. So I'm surprised Dr. Bhaskar didn't hit me in my hands.
No, I thought you were pushing the wire.
No, you're right. You're right. So I'm going to go ahead and just let him pull this device back into the. Pull this device back. There you go. Ooh, okay, that's okay. He ate too much breakfast today, unlike Ray. So you know. So we're going to show me the filter. So we're going to walk this back. So Dr. Wiley, to answer your question, we clearly, you know, will use this in native SFAs as well as in ISR. Okay, let's walk this out slowly. Don't bend the wire. Don't bend the wire. Yep, close. Exactly. You see, this technique that Dr. Bhaskar is using is very important. You want to be very close because you're working on flimsy 014 wires. You've got a device that's not that bulky, but clearly is across over the iliac into the contralateral side. So therefore, you're going to have tightness bringing it out. So it's important if you bend this wire now, you might have to pull the filter out. And believe me, anybody who's done a lot of interventions has had to do things like that. So at this stage, he's just following good discipline, holding the wire close to the catheter, walking it in slow increments, and also I'm on fluoro, looking at the particular filter to make sure that it's okay. A little saline for him, right? A little saline. Put it in a syringe. Thank you, Chris. So I'm just going to score some saline for him and just drip it in so as he comes out.
You have the ground slam there?
That's actually the filter wire, the wire that has the on the Covidian device. So I don't know what, I think it's sort of like a mailman type wire. I don't think it's probably a heavy duty wire, maybe the Iron Man or something like that.
I thought it was a BHW what they had, but I'm not sure.
That's good. Keep going. You're doing great. Yeah, I'm not yet. I will. I just want him to come out. It's very tight, Liz.
It is.
A little more. You're almost there. So it's important, this particular things, to demonstrate it properly.
The filter's moving back and forth.
I know, Dr. Wiley, but believe me, this is a tough one right here to get this out. It's just tight around the catheter. We've been inside that body. We probably have some debris. No control. No, but now I got it. Okay, good. Now we got it.
Give a wait.
Yeah, it's really tight. I mean, I'm literally pulling it very, very tight. Okay, now we're done with that laser, in my opinion. Now I'm going to ask Dr. Varghese to take a nice angio for us, and let's see what we see.
DSA.
Okay, 48, Bhaskar. That's good, right there.
No
good.
DSA?
That's fine. DSA, please. Okay, ready?
Hold on. Let me open up the windows.
No, it's fine. Inject. Whoop. That was my mistake.
Are you going to image the filter as well? See if it's full or not?
Hold on, Dr. Wiley. Come forward, guys.
Hold on, let me.
Okay. Little technical difficulty going on. All right, cool. We're ready to roll.
I want to give a little test, flush all
Yep.
the saline out.
Mm-hmm. A little more. It's refilling. What were you saying, Dr. Wiley?
No, I would like you to
Just
take a
a
picture of the filter, see if
I
there's
will.
anything.
Definitely. We're just letting it refill. Okay, good. We're ready to take a picture. Go ahead, inject. Wow, look at that.
Oh, beautiful.
That's beautiful. So now we're going to go take a look at our take a look distally. Ready?
You want to?
It's okay. Inject. Looks like the filter's got something in it.
Yep.
Okay, and I think that's a very important point that Dr. Wiley and Dr. Sofer bring up, is that when we use these filters, you got to be extremely careful because no matter how you do it, things are going to embolize. Matter of fact, what was the percentage in the trial with distal protection, guys? In the Excite trial, anybody have an idea? Was that presented? Dr. Bhaskar, do you remember?
I don't remember seeing that, but I saw there was more distal embolization with the laser, but was not statistically significant.
Inject, but I think Dr. Dipple did use protection. There you see that, guys. You see that chunk. So those are the things that I think you have to be careful about and why you want to use a distal embolic protection. So what we're going to do now is we're going to capture the filter, right, and then we're going to rewire this, and then we're going to decide on our final therapy here.
Flush.
Flush.
I'll just flush this end.
Sure. Dr. Sofer, is there any particular distal protection you like better than the other, or do you just think they're all the same? And what's your algorithm for using them, Dr. Sofer?
I think you want to use it as early as possible and take it out as late as possible. But I think the spider, have the advantage that you actually can use whichever wire you
Actually,
would
that's
like
a good point.
to.
Let's leave this in. Actually, you bring up a good point. There's no reason for me to remove it at this stage.
It's not full.
Yeah, you're right. Absolutely. I think we're going to go ahead and work here. So, I'm going to break away from the Excite trial protocol and use a 6mm angiosculpt to expand this lesion. Again, like I told you, the luminum gain that I'm going to get from this particular device, it's really going to add to, in my opinion, the patency of this particular vessel. So we're going to go ahead. We're going to prepare the angiosculpt, and we're going to go ahead and inject. Now, I know that Dr. Sofer was talking about using a DCB. Dr. Wiley, would you stent this with a drug-coated stent?
No, I don't think, based on the data that was just presented, that we need to do that.
Okay.
It's very compelling what we have right now.
That's perfect.
Right.
So I think we're all. Dr. Sofer, when do you use covered stents in in-stent? I know prior to this trial, we were all doing our own algorithm, in terms of treating. When do you use covered stents in these particular trials?
I don't.
You don't? Okay.
No. The thought was that, you block the tissue from growing, but I think to add another layer of stent inside a stent, just make the vessel so stiff, and you lose the ability to the torsion and deflection, and you just create more problems, with stent fracture.
No, low man.
With stent fracture and inflammation, and you just increase restenosis. I don't see a reason to use a covered stent in stent restenosis.
No, the other thing, you still see some collaterals preserved even though you have stents there. It don't mean you put a cover stent, you lose them all. And if you have poor distal runoff, you increase the risk of acute thrombosis.
Right.
Well, Dr. Wiley, it's interesting. I was in a panel, and I don't want to say where. And what happened was the discussion was that in the trials, the stents don't really go down hard. And my argument to that was, most patients do very well in clinical trials because they're so well followed. Go up. They're so well followed that you got a coordinator calling them, making sure they're taking their medicine, et cetera, that in the real world situation of where all three of us here and Dr. Varghese work, it's not quite in that manner. Go up, Crank.
Yeah, I would go slowly here. I would go slowly and try not to go more than 4 atmospheres.
Okay, gotcha.
And many times if you wait a little bit, it just
and that's what we're doing. We're going very slowly. We're only at 3 atmospheres right now. And you can see the expansion at 3 atmospheres is phenomenal. Right. There's that area where Dr. Varghese had the trouble, you could see is clearly a problem area, Dr. Varghese. You could see that.
Yeah.
So I'm glad you brought that point of what clinical trials show, but as you know, most of these trials do not have patients with impaired distal runoff. So in that case, this is probably not a problem. But in real world, we have patients that have a single vessel runoff, where cover stenting may be a problem.
Well, what happened was the discussion was so robust that with all the panel really believing that the covered stent works really well, and I said it does work. However, I do believe that there is this problem with thrombosis that occurs, and they said that the trials don't show it. And my exact retort was that the trial patients are so well followed that in general you're not going to see these complications.
Correct. 2
things I want you to see. One is, as you guys definitely see, is that even expansion of the stent of the balloon. You can see that this 7 millimeter stent with a 6 millimeter angiosculpt clearly is showing a wonderful expansion under very low pressure of about 5 atmospheres is where we're at. So therefore you see that at this stage we're going to get a little more dye here. So we're going to just go ahead and actually you can do it like that. Yep, that's smart. So we're going to leave this up for a little bit to really tack everything up, right? And then hopefully we'll be done with this. Patient's a little uncomfortable, I can tell. He just moved. So therefore, we're obviously negative. Now we're obviously going to let this balloon come down. Also, the second thing, the problem that the older engineered version of this particular balloon showed was that it would have that sort of kinking of the cables. The kinking of the cables don't occur, so because of the way this product has been engineered now. Lastly, you saw the pretty rapid deflation of the balloon. The balloon deflates rapidly, and so now what we're going to do is we're going to go ahead and get the ostium, and then we're going to decide. So we're going to go all the way up to here. Again, I'm pinning the balloon, pinning the wire, pulling the balloon back. And I'm just going to go up to the ostium if I can, right about there.
Prakash, what was the size of that balloon?
It's a 6.0, Dr. Wiley.
6.0.
Yeah, I think trying to stay as low pressure as possible is important, not to cause barotrauma and initiate again the process of restenosis.
I think I agree with you. I think less is more in these type of cases, and but I just look for. I know Dr. Bhaskar looks for just a good expansion of these particular balloons to really get the maximum luminal gain that we can get with the least amount of pressure. So right now he's at 3 atmospheres, and he's just gonna go up till.
You see, it's almost fully expanded.
Yes, it is 3 atmospheres. It is, and he's just gonna go up. Maybe go up another atmosphere. There you go. So there, now you've got it at 4 atmospheres. I'm going to leave it up for another minute, and then what we'll do is we'll go ahead and take a nice picture, and we'll see what we have. So, in recap, Dr. Varghese, any thoughts? I know you did that case. It was a very difficult case. Right. When you went down, what did you feel? Maybe you could tell the audience on what you felt.
Right. I think, when you first initially tried to go through, we kept getting deflected off and going outside of the stent, and I think we created a channel and kept going into that outside channel. We couldn't get back in and find the true channel where you were able to find it. And
so when you pushed, did you have a 035 glide, or what were you using?
We initially started with the glide wire. We started with...
was it looped or straight?
We started with the loop up top.
Okay.
We brought the loop all the way down to the cap.
Okay.
And then we tried with that in different, different angles and trying to turn the catheter in different ways and trying to get it through, but we were unsuccessful with that.
Huh? See, that's
Very
very
tough.
interesting, Dr. Wiley, because if usually when you have a straight wire and an in-stent, it can try to get underneath the stents. And the classic teaching that we always teach our fellows is that the loop will prevent it from getting through the strut. So it's interesting that Dr. Varghese actually went with a loop and was still getting into that strut. So the question could be, was there a stent fracture at the site that was actually causing this to occur? And these stent fractures can be quite difficult to treat and deal with. Any thoughts on your end, Dr. Sofar, on how you cross these? Do you generally use a wire catheter technique, or do you use a crossing device? Now,
Yeah, I usually use an 035 system with a quick cross or a trailblazer, and usually a straight stiff glide.
okay.
Which I let it, a few millimeter beyond the tip of the catheter, and I try to advance. Usually it goes smooth. If there is resistance,
You'll leave it negative.
I try an angle tip catheter to redirect it to where I want to go. But I usually go with this type of lesion with an 035 system.
What about you, Dr. Wiley?
Likewise, I prefer getting a 035, perhaps angle glide wire, have a vertip catheter behind it, and advance and keep the vertip catheter perhaps 1 inch behind the tip of the wire.
So what do you think is the most common cause for failure of crossing these? Do you think it's what happened to Dr. Varghese? Do you think, what do you think? Let's get the IVUS guys.
IVUS is here.
I think the big problem is when you get behind a stent through a stent strut and you don't recognize it. That's where people usually get in trouble. And from there
So
on,
I'm wondering whether you and Dr. Sofar can give some tips. I know I tried to give my tips as to what I would do. How do you guys determine whether you're in the stent strut or not?
I mean, obviously you take different views, to see. But, the difficult lesions would be, when you have a flash occlusion, which terminates in a collateral, and then you sometimes have to go retrograde. You have to go from below, either a popliteal stick or pedal axis. But those are the difficult lesions. But for the most part, with in-stent occlusion or restenosis, usually, usually you should be able to go in and to stay inside.
Okay. So, that's a great point. I think that's the option of getting distal access and coming proximal is important. Now, I just want to preface the IVUS by saying, the IVUS is going to show things that we probably don't want to see, right? But at the same time, I think it's important to understand, how this particular lesions look, and also to really understand the amount of luminal gain and expansion that we've been able to get with this particular device. So let's walk it back, Ray. So Dr. Lascano is going to walk it back for us. He's outside the stent there, and I'm just going to let it come back into the stent. There you see. See that you see that, Dan? That's interesting. So right at the distal edge of the stent, you have 2 lumens, right? So you see, and I'll take a picture here to show everybody. So now the question becomes is, what do we want to do here? Whether you think this will flop one side or the other, or do you just want to leave this alone? Let's see. As we come back now remember, Dr. Varghese had trouble. So this is the dissection plane that we were dealing with, right? And I think the IVUS shows you, a lot more than you want to know. You see, which is also important in some ways. You can see distally, you got that one problem. So maybe a distal stent may be necessary here.
You have to stent it.
Right. Proximally, you see that you have dissected, but you don't have that 2 lumens that you're seeing. You've got dissected planes here, but you don't have 2 lumens. There, it's down. It's not exactly 2 lumens, and it's flapping in the breeze, which is exactly the area that Dr. Varghese had trouble. This is exactly the area.
Although the classic teaching is that non-flow limiting dissections, you could leave them alone.
You're right, and I think that's what we need to see with our injection. I think the IVUS has told us that you have this problem. This is where Dr. Varghese had trouble when he was doing it, getting into that plane. And now we'll see how far up this dissection does extend. You can see I'm staying on fluoro so we can actually see, but you can see here, there. Now you've got plaque. So let me bookmark this spot. So this way we know that up to here we have to stent, right? So let me just bookmark this.
Yeah, not necessarily. I think the distal one
There you go.
have to, but the more proximal one was
Keep
not
coming, buddy.
as tight.
Yeah.
Now you can see the plaque is fine, right? You see that the plaque has been pushed aside. You see that the laser has done a great job of actually excising the plaque throughout, and the angiosculptor has done a great job of giving us the lumen that we need. So the problem that Dr. Varghese had was clearly illustrated by intravascular ultrasound, and I'm going to correlate that with the angiogram that we see in a second. So we're going to come back out now slowly. Dr. Lascano's pulling it back here, and we'll see in a second. And you can see this beautiful, how wonderfully it's been debulked, how, yes, you have plaque, but it's pushed aside. And clearly you have a wonderful lumen. I think the angiographically, the proximal edge of the stent is going to look great. The mid-body of the stent is going to look great. The distal may even look great. And then we have to make a group decision. And that's why me and Dr. Varghese are lucky, because you guys are here to tell us what to do. You know? So
Well,
Dan,
if the ultrasound is not going to change management, the question is then why are you using it?
well, see, that's the difference, and that's exactly what I was going to ask Dr. Sofer. See, for me, Dr. Sofer, I use the ultrasound, and it does change my management. See, now you're out. To me, I do not leave that. Can you go to that first one, Sinan? You'll see now when our, yes, take out the ultrasound. You'll see when we go to that proximal lesion, right, Dr. Wiley? I mean, distal lesion, so sorry,
right.
distal, all the way distal. You'll see the 2 lumens. You see that? That's uncomfortable for me, because if, question is if it flaps, it slows down flow, whether it's going to thrombose, all this hard work that we did is going to go away.
Right.
This is an area where I may choose to put a stent to go ahead and tack this up and follow what Dr. Sofer said, which is really put a stent across that distal edge and not so worry about, a long stent, maybe a short enough stent just to go ahead and tack this up.
Right,
Put me on
right.
DSA?
So what stent would you use?
Well, that's the next question, and that's what I'm going to throw it out to the two of you guys. Ready? We're going to go ahead. DSA? Inject.
On DSA.
I think if you take, you would see that area on the angiogram. If you take a good angiogram, you would see the haziness, and you see that area
Which is exactly what I'm going to do here now, Daniel. I'm just going to go with a nice DSA, not pan it. Inject. Right there. You see the haziness, Jose?
Yes.
Yeah.
You see how there's two areas of flow? So this is the worry. I mean, there was a provisional stenting in the Excite trial, if I remember right. And so that was also looked at as a non-TLR analysis, as Dr. Bosco went over with you guys. And still the laser showed a better outcome as compared to balloon alone. So I think here, the question now becomes is what stent? I have my theories. I'm very curious to think what you guys think.
So one question, at what number does the stent ends? Because you're using digital subtraction and I can't see.
It's 26 or
25, 26.
26.
Okay,
So
it's down there.
I would cover from
26.
21 to
Give me the
21 to
filter,
27
Walk.
maybe.
So that region is right at the Hunter's Canal where there's a lot of radial forces there. Would you consider a supera stent?
Don't open. That's very interesting. And, we, as you know, me and Dr. Sofers had the opportunity to have our conference last year where Dr. Burkett, go ahead, inject. I just want to check the filter. Dr. Burkett talked about the Zilver. And here, because you have a stent and you're going to stent inside the stent, I think you have a double layer of protection here, and I don't know if you need a supera. So I was going to put a Zilver PTX. I can be talked out of it, but that's what I was going to use.
Yeah, I think that will give you probably the ideal long-term results. Although we don't have
Data in this
data.
in this lesion subset. And I think, Dr. Wiley, I think this is one where you can. The other one is I can put Supera, because Supera also has single registry data. Don't open it, guys. Registry data that with the Superb registry that's core lab adjudicated, that also shows good results. So while I go ahead and pull this this filter out, why don't you guys tell me what you guys would do?
I would consider putting a supera stent.
Okay.
Again, we don't have any data, and I don't think there's a right or a wrong answer since there's no data to justify either approach. But just the fact that it may extend outside of the previously deployed stent, I would consider a supera.
I think that, if you extrapolate the cost analysis of using a drug-eluting stent in the long term, I think you save money, even though it's going to be an expensive procedure right now with laser and drug-eluting stent and scoring balloon. But
Come forward.
But I think if this has a chance to have a 90% patency at 1 year, or maybe 2 years, that would be a good thing.
I mean, I think those are great arguments. I am going to err on the side of Dr. Sofer, Dr. Wiley.
Okay.
The reason is I agree with him. I think that if we can do something here, especially since it's in such an important area. Can I have the 035 Supercore? Yep, and show the debris that we caught.
Yeah, and every time we do these procedures, it's also risky, for the runoff vessels and all that. So if we can reduce that recurrence as much as possible, I think, and we have the technology, why not use it?
And that's exactly my thought.
And that's the debris from the spider filter.
Yeah.
So a lot of stuff does embolize, and all of us who do a lot of these difficult procedures know that embolism is part of what we do every day. So I just want the audience to really see that and really recognize that it's not that the laser embolizes or X doesn't embolize or whatever. That's not the point here. The point is that we clearly want to be able to prevent and prolong our procedure. We'd like to get the procedure done quickly, right, and not be prolonging our procedure too much. And I think once you do, embolic debris into your distal vessels, then that's obviously going to prolong your procedure. So now I'm going to go ahead. I'm going to take the Zilva PTX, and I want to really do this on a roadmap.
Right. Before we need to make sure that the wire distally is inside the lumen you want to, and it looks like it is.
I agree with you, Dan. That's a great point for the home. Give me a little die, guys. I think that's a great point that Dr. Sofer gives, especially since we have two vessels. See that? So you really want, two lumens within the stent.
Within the stent,
yeah.
Right.
So you want to make sure that you're on the true lumen, and there you are. And so now we're going to go ahead and we're going to place the stent. So let's roadmap here.
Yeah, roadmap.
Inject. Great. So now you've got that particular area that you have to cover. The distal edge looks phenomenal. So I am probably going to come a little bit out here and then go into the stent. So now I'm just going to go forward, right? And it's important with this particular type of stent to do it on an 035 wire. It's a great stent, okay, in the sense that the data is very, very phenomenal. But clearly, it's not something that I think you want to do on an 014 wire. Question here, guys, you want me to go a little further? You like where I am?
Are you at the edge of the prior stent, or where are you?
I'm going to show you, Dr. Wiley. I know you. There you go.
I think if you cross the adductor canal already, maybe you can go a little further.
You want me to go a little further? I agree.
And you have what? It's an 80 millimeter.
It's 100. So we'll start from here.
Yeah. So you have enough.
And we're up to here. I think that's perfect. Go ahead, Dr. Bosker. Dr. Varghese, you want to deploy this?
No, go ahead.
Good. So we're just going to go ahead and deploy. So you took off the safety here.
You're on the floor, right?
Yep, you're on the floor. A little bit.
What size is that stent?
It's a 6.0. It's the largest one they make. We ballooned with a 6.0 angiosculpt. You can see the stent takes a little bit of push to the right.
They make a 7.
I'm sorry?
They don't have a 7 millimeter?
Oh, they do have a 7, I believe. Okay, give me a 7, guys. It was my boo-boo. Walk this out. Yep. We're going to go with a 7. Thanks a lot, Dan. It was my boo-boo.
Yeah, they have a 7, definitely.
Thank you, my friend. Because we used a 7 stent prior. Okay, we're going to go with a 7.
I mean, this is a big vessel, so I think.
Oh,
that the
absolutely.
7
That was a very good pickup.
Yeah, that's why
Great.
pushed it.
Yeah, he flushed it.
All right, we're going to take it back down again. Okay, Dr. Bosker. Again, he's going to take off the safety here. Get us a 7.0 high pressure balloon, guys.
No, I would go with a 6 then, with a 6 balloon.
Ready? Go ahead. Here, look at it.
Because we usually upsize the stent by a millimeter or
Push
2.
forward.
Go in.
I don't know. Go in. Go in. You can see the stent tends to stick, and Cook has been working on obviously getting this fixed. But I think our field is so rapidly improving. I mean, with the addition of the spectranetics data, with the Excite trial, I mean, it's really phenomenal. And having the new device that really works well in this particular type of lesion, I think all these other issues with these kind of sticky stents, all these things are going to change very soon.
Now, Prakash, the stent is extending,
good
a
there.
few
Come back.
millimeters outside of the other stent. When you use a 6,
We're going to pull it back
as
now,
Dr.
Doctor. We're going to pull it back a
Sofer's-
little bit, right, a little more, right to E, right there. We're going to deploy it here, Dr. Wiley. Because I know that the distal edge of where the collaterals formed was also diseased. So I'm going to go ahead and deploy it right here. Go ahead. You're taking too long. There you go. Beautiful. He's right on the spot. Right there. A little more. Beautiful. Beautiful. Nice. So the key here is not to elongate the stent. And you'll see here Dr. Bosker will not elongate it. You can see how fibrous the distal cap is by that fact that the stent is actually bent in that area. Now we're going to go forward, and that's why I chose to cover it. Keep coming. You're doing great. You can see here that right around this area was that lesion right around 20. And you see again there's a little bump up. And then Dr. Bosker is going to finish deploying right at this stage. Wonderful. Now walk this out, my friend. Now we're going to go ahead with a Dorado balloon. Yeah, well, that's fine. Give me a 200. I want to go with a high pressure balloon here, which is a non-compliant balloon. And I really just want to really blast this distal edge.
No, PK, I would stay. I would not go. Beyond the stent that you put at high pressure. So I would just try to get a shorter balloon and concentrate in that lesion with a 6x40 or 6x60 balloon, non-compliant.
That's actually a great point here. But what I'm going to do is just go ahead to low pressure, like you said before, and just go ahead and just tack up the entire stent up against the other vessel.
It's flushed.
So I'm just going to up against the other stent. So here we know that we we've already ballooned with the angioscope. So I think we're not going to lose anything by going with a longer balloon just to tack it up nicely. So rail, guys, nice rail, please. So this should be the last part of what we do here. I know we're about 30 minutes over, which is rare for us, but I think this particular case merited a really good discussion. And I really thank Dr. Sofer and Dr. Wiley for really coming here and discussing this with us. So I'm taking extra care not to come out of the distal stent here. And we're just going to come forward. I'm going to go up really slowly with this 6 millimeter Dorado. Go up. And clearly, all I really want to do is expand that particular one right there. What's the matter? A little spillage? A lot? Keep going.
1, 2.
It's from the saline, I think. But it's attached, right?
Yes, it has.
Okay, 3, 4. It's very important to notice, Ray, watch your legs. Very important to notice how the balloon does stick out a little bit above the marker. 5, 6, That's it. Pointer. Okay, you can see here that we're just slowly leaving it at 6 and letting it expand. Pointer. You can see again, keep pointer. Right. Really trying to get that distal edge. Pointer. Fundinator.
Although that stent is not opposing to the prior stent.
I know, that's why we're going up a little bit higher here. 8, 9, 10, 22 போயிட்டானா போயினேரு. There you go. A little more. But remember, Dr. Wiley, that's where Dr. Varghese had that
Yeah.
So, you may not get the perfect apposition that you want. We're going to go up a little bit higher pressure here than we thought. Keep going. And that's the beauty of the non-compliant balloon. I think, the fact is you have a beautiful non-compliant balloon. You can see here, Dr. Wiley, that there's well opposed. It's just a plaque here at this site is so hard that it's not going down. Down?
Right.
I think we're done now. We'll take the last few pictures here. Negative. So I just want to recap as we're doing this. So clearly this is a very challenging case because we had a dissection plane that was there. We had an experienced interventionalist, who had trouble crossing it. So clearly there were certain points that we want to talk about.
Yes, sir.
You can walk this out. You want to talk about first is to always take good angiography above and below. So that means look at the inflow first, look at the outflow. Make sure you know your vessels prior to starting. Second, engage the stent like Dr. Sofer described with an angle catheter not to get behind the stent struts. Third, always as you're traversing the stent, always look at the catheter in multiple views to make sure that you're not outside the stent strut. Fourth, if you're having difficulty and you're getting into a collateral, use the angle catheter to rotate away from the area of dissection and find the true lumen. 5, once you cross, go ahead and place a filter if you think it's clinically warranted. 6, once it's clinically warranted, you go ahead and decide on your mode of therapy. Obviously here we were very fortunate. We have the EXCITE trial that we're very excited about, again a pun. But the point is we're able to say, show me distal first. I'm going to start distal to proximal. We're able to for the first time have data to actually guide us in the therapy of these patients, right? So you actually have data to guide us in the therapy of these patients. So the data clearly shows that in this lesion subset that the laser PSA that the laser angioplasty is superior to angioplasty alone, and so therefore we chose to do that in this particular case. 8 is make sure you go ahead and take an intravascular ultrasound or some sort of imaging modality if you find that there any sort of haziness or anything like that you find. And obviously we went through the discussion very, very clearly as to when you should go ahead and intervene with another stent. Right here, guys?
So that was very good. We didn't lose any TBL.
Yeah.
I think it was very important to use the filter.
Beautiful. Love it.
Very nice job.
That's perfect. Show me above now. So, Dr. Wiley, Dr. Sofer, any final thoughts before we sign off from the lab?
No, I think that was a great demonstration.
And I cannot reinstate enough that finally we have good randomized data, something that is very scarce in the peripheral vascular or endovascular arena. Most of what we have are registries which have a lot of limitations. As we all know, finally we have randomized control data.
I'd like to thank from the cath lab Dr. Sofer for coming and really sharing his wealth of wisdom with us. Dr. Varghese, thank you so much for bringing this patient, which really demonstrated to our audience the difficulties and challenges of treating in-stent restenosis. I'd like to thank our team here, the sponsors, and especially Spectranetics for running the trial and giving us the data that we need to be able to do this. And we'll see you back next month. I mean, I think the blog is there, so log on to the blog with us, and let us know your thoughts on this particular case and any questions that you need answered. We're ready to do it.
Prakash, the next peripheral intervention case will be in November 26th. The next CCC live cases will be in November 18th. The next structural heart live case will be in December 9th. And there's going to be a summary of what was done in this case later on. Thank you.